Good morning, members, officers and members of the public watching the meeting of the City of London Corporation's Health and Social Care Scrutiny Committee meeting today, Wednesday the 29th of October 2025 at Guildhall. The public element of today's meeting is being live streamed and those participating in the meeting have given consent to their inclusion. The recording will be available on the City Corporation's YouTube channel following the meeting and will be retained for up to 1 municipal year. The first item is apologies. I haven't received any.
Are we forward?
Yes, we are indeed quorum, yes. Yes.
Yeah.
And then the next item is members' declarations.
Has anybody got any declarations they wish to raise at this point? Okay, then moving on.
Thank you. Item 3 is the minutes of the previous meeting on the 7th of May to approve.
Is everybody happy with the minutes of the previous meeting? Okay, that's agreed.
Thank you. And item 4, we have Claire Solly. Thank you for joining us to talk to the item City and Hackney Safeguarding Adults Board Annual Report 24 to 25.
Good morning. Thank you, Chair. Morning, everybody. My name's Claire Solly. I'm the independent chair of the City and Hackney Safeguarding Adults Board. I am the new chair. I started in June of this year. Following your long-standing chair, Dr. Adi Cooper, who was the independent chair for approximately 10 years. So I'd just like to take the opportunity to thank Dr. Cooper for a comprehensive and helpful handover to myself. So I'm here today to present the 24-25 City and Hackney Safeguarding Adult Board Annual Report. The copy that has been sent to you in the pack for this morning's meeting is not the final version that will be published on the website. I've had confirmation yesterday that the final version has come back from the publishers and we're just waiting to proofread it finally, and that will be uploaded hopefully by the end of the week. So the chair forward and any small grammatical errors, etc., will be addressed before the final copy is uploaded, but the information will remain the same. So I think it's probably helpful just to say a bit about the Safeguarding Adult Board. So the Safeguarding Adult Board is a statutory board under the Care Act 2014. We have lots of statutory duties that the local authorities, the lead agency and partner agencies need to meet in relation to adult safeguarding, and one of those is to publish an annual report. You'll also note at the bottom of the annual report there is reference to our new strategic plan. So another duty that we have as a Safeguarding Adult Board is to publish our strategic plan. So I'm really pleased to say that following consultation with key members and residents, and using information from our self-assessment and our away day, we have published our strategic plan, which will run from the 1st of April 2025 until the end of March 2028. And details of that are on our website now. Similarly, our work plan moving forward for 25-26 is also on the website, and those are referenced at the end of the annual report. The purpose of the Safeguarding Adult Board is essentially to prevent abuse and neglect happening in the first place. And there's lots of things that we do to achieve that, and those are detailed in the annual report. But it's also really, really important, and one of our key functions is for the Safeguarding Adult Board, the sum of its members to be greater than those as individuals. And again, I think the annual report is a really, really good demonstration, certainly as an incoming chair, of the strong and effective partnership that you have across City of London. I think that's evidenced, one, in the data that's been presented. So you can see residents are at the centre of the safeguarding activity, but also the case studies that have been produced, not just from the local authority, but from partner agencies across City of London. So it's really critical that the SAB is assured that there are effective multi-agency adult safeguarding systems in place, and that those absolutely keep the adult at the centre. So understanding what they want to happen at a pace that's right for them. And the figures in relation to City of London are impressive. So 62% of people were asked what they wanted to happen. That will very unlikely ever be 100 for lots of reasons, but that 62% is an impressive figure. And then out of those people that were asked, 69% had their outcomes fully or partially met. In terms of the data that we can see within the report, and I will take the report as read, but if I may just highlight a couple of areas. So there's 49 safeguarding concerns. So what that means is referrals into the local authority for this period that the annual report covers, 24-25, and that mirrors the previous year in City of London. Interestingly, from 2016-17, the national trends which City of London mirror, where there were increases in the number of safeguarding adult referrals. That's largely attributed to safeguarding moving to statutory footing under the Care Act, which is 2014 implemented in 15. But interestingly, City of London's seen a small reduction in the number of concerns that have been recorded. So 57 in 2020-21, as I say, to 49 in 23-24. And there can be lots of reasons for that. It can be in relation to the way systems are used, the way things are recorded, but it is a notable difference, a uniqueness in City of London in relation to the national trends. The types of abuse are listed within the report, but to briefly summarise, so self-neglect was the highest number of a type of abuse that we received concerns in relation to, followed by neglect, and then financial and physical abuse. The number of referrals, concerns that move into full or longer term inquiries, the conversion rate is largely similar. With that being 63% of the concerns the year before, and for 24-25, 61%. 21 full safeguarding adult inquiries were complete for the period 24-25, and in ascending order, those relate to neglect at 32%, self-neglect at 29%, and financial abuse at 18%. The demographics for the people City of London receive concerns about are 68% relate to people who are of white ethnic background, and 60% relate to people who are 65 plus. I'd just like to take the opportunity to thank partners for their contributions to the Safeguarding Adult Board activity over the year, but also their contributions to the Safeguarding Adult Board's annual report. Those successes are against a backdrop of increasing complexity, increasing pressures as a result of social and economic challenges and the impact of COVID. So it's a particularly challenging landscape in relation to adult safeguarding, and the same with children's safeguarding and other pressures across the system. But I think this report really demonstrates that the partnership continued to meet that challenge. I've got three final points, if I may. So you'll see from the annual report that there were 2 safeguarding adult reviews published across 24-25. So the Safeguarding Adult Board has a statutory duty to carry out safeguarding adult reviews when the statutory threshold is met. So for these 2 reviews, one related to a gentleman called JL, and he sadly died in May 2023. He lived at home and the concerns were related to self-neglect. The Safeguarding Adult Board has produced a 7-minute briefing, which is available on the website, and there was a number of improvements across the partnership, particularly in relation to the escalation processes. So if something happens, there's risk that's increasing, or things are getting stuck and not moving forward, or specialist advice is required, the board has implemented different escalation routes, which are well embedded, in my view, across the partnership. The board has also included housing representation on the board, and hospital discharge processes have become more robust. So these were some of the key themes that were related to the Safeguarding Adult Review GL. The second Safeguarding Adult review related to a gentleman called Steve, who sadly died in November 2024. And Steve was a homeless gentleman. And the key improvements across our system in relation to Steve were in relation to advocacy. So making sure that people are supported where they need to be to convey their views and share what they want to happen. The multi-agency approach in general, making sure you've got the right people around the table as you need them. We've strengthened our training in relation to self-neglect, palliative care and the Mental Capacity Act. Other key highlights within the report refer to our training offer. So the Safeguarding Adult Board is a comprehensive training offer which is available across the City of London to partners, and we contributed to the national footprint as well. The case studies in the report, again, I think reflect the really strong partnership, the engagement, the commitment to the Safeguarding Adult agenda and making sure that we're getting the right outcomes for people, supporting them with recovery and resilience and preventing abuse and neglect reoccurring. So there's lots of different elements to the report. I think there's lots of detail there. As an incoming chair, the key areas I would suggest the board needs to strengthen is the multi-agency data. So the data set is very much focused on the local authority data, which is collected at the moment. So one of our new subgroups, the performance and quality assurance subgroup, is focusing on making sure that our dashboard is multi-agency. So getting health data, mental health data, police, fire, etc. So we're working on that. The other key area that we need to improve on is around community engagement. So within our strategy and our work plans, you'll see that top of our work plan is a community engagement strategy. So we're just about finished in our draft of that. And that's really, really critical for a number of reasons. One, making sure that we are connecting with people that we don't receive referrals about. So the seldom heard voices within our communities, that we understand and are assured people know what safeguarding is, what types of abuse are, and what they do if they have concerns about people, and what happens when concerns are reported. Really, really fundamental that that is in place. And then the third part of that is learning what people's experiences have been of our multi-agency response to safeguarding. Are we getting it right? Because that's absolutely critical. Then making sure that we're co-producing and working with our residents in relation to absolutely everything that we do. So our policies, our procedures, our approaches, how we feed back to people, etc. So I think those are the two main areas that the board isn't quite where it should be, and there's lots of reasons for that. COVID majorly impacted my understanding from my handover in relation to community engagement. I think there's still some recovery that's happening. Secondary to that is the move from the previous chair to myself. So these are things that we will be picking up as a priority for the remainder of this year and into next year. So yes, thank you very much. Happy to take any questions.
Well, thank you very much, Claire. If I can just sort of kick off about the community engagement strategy, how do you sort of perceive the City of London residents being involved in that, and particularly with a view to will have their input in shaping it, the way it's going to progress?
Thank you very much. So it's absolutely critical that the Safeguarding Adult Board builds on what is already in place. So we know that people are time poor in terms of our partner agencies. We know residents don't want to repeat their experiences to lots of people as well. So what we're doing is we're building in our community engagement strategy, and this is a learning exercise for me as an incoming chair, what you already have in City of London. So for example, as part of my induction, I've met lots of people across Health Watch in relation to carers. I attended the joint Health and Wellbeing Board meeting last week and linked in with the voluntary sector leads. So I'm meeting up with them. So really embedding in our engagement strategy all the existing pathways you have across City of London, which are extensive. Doing things in person, so going to community events in person and sharing safeguarding messages and getting responses. We're also reinvigorating our Safeguarding Champions model. So what that means is that we're using these existing networks, so leaders within communities, so the community, voluntary and faith sector, to become safeguarding champions and help us, A, deliver those messages, but also receive messages back from members of the public.
Thank you. Deborah.
I've got two questions, Chair, if I may.
Go ahead.
But Claire, first of all, I did find your report very clear, and I found the sort of presentation of the facts easy for me to understand. So I really did appreciate the report. So thank you. I also found the case studies very useful, and my sort of first question is really about case study number 6, where you've got the lady that was suffering from domestic violence, and I kind of wondered, because it explained what had happened to Sarah and her experience, but I wondered, it did seem to suggest that work needed to be continued in the community, because there was obviously a number of perpetrators of the abuse, and it's possibly a question outside of the committee, but you kind of wonder, she's been supported, but what actually happens to change the behaviour in the community to make sure that the next Sarah doesn't get the same treatment? So that was question 1.
Mm-hmm.
The next question, I think if I just do both, because I think they're linked in a way, is what David was saying also about community engagement. And I do think that there's a kind of almost like a societal issue that I think people still are a bit reluctant to report safeguarding concerns, because there's this image people have of the social care team whizzing in and taking people into care. So people are almost reluctant to report concerns because they think there's going to be this negative consequence.
Mm-hmm.
And I think so society, communities need to understand the benefits of expressing concerns and knowing that there isn't just the kind of nuclear option, that there are staged approaches to support and to really encourage people to come forward. Because I have been surprised, recently one of my neighbours is concerned about a family member who is hoarding, and just would not dream of actually reporting her concerns to the social services teams. And I've been having to sort of gently counsel her to the sort of different stages that might be taken and how the person would be supported, not penalised in a way. But it kind of surprised me at the lack of knowledge and the strength of almost fear. So sorry, a bit of a long ramble there, but hopefully the two questions are kind of linked. So thank you.
Thank you very much. So in terms of the first question, when we do risk assessments in a safeguarding adults capacity, it's a holistic assessment of risk. So the safety of the adult is obviously paramount, but we also equally look at risks to others. So if there are children in the property, we're working closely with our children's safeguarding teams in relation to supporting families as a whole. So it's a think family approach. There are support services where the perpetrator, they work directly with perpetrators of domestic abuse. So working with them to help minimise risk, support those people not to repeat the behaviour that they have been, the abuse that they've been perpetrating to others. And a really important part of the safeguarding adults stages, if you like, is that recovery and resilience. So for the adult who's experienced the abuse and neglect, but it's also really important, as I say, to work with the perpetrators as well. So there are a number of programmes people can access to do that. I think it's important to say there is still developments and work happening in that space in relation to the availability of those programmes, and if people wish to engage, choose to engage, because some people won't. So there's lots of different things that we need to consider, but it's absolutely front and centre to the ongoing monitoring. The London multi-agency policies and procedures for safeguarding adults have just been updated, and the City and Hackney Safeguarding Adult Boards have signed up to those. And there is a stage within that about this ongoing monitoring. So, you know, if things are being closed off, it's that ongoing monitoring of risk to see what the plans and actions that have been agreed, the impact of those for the adult, for anybody else at risk, and it also will consider the perpetrators of the abuse as well. In relation to community engagement, so I should have said at the beginning actually, so I'm a social worker and have worked in adult social care in lots of different roles, but what you've described as often being the social worker who would be visiting people to carry out safeguarding inquiries, I think you're absolutely correct. It's the information they don't have about what happens next. So people are frightened that they'll lose control, that decisions will be made without them. And this is a really important space to reassure that is the complete opposite that happens. So making safeguarding personnel is front and centre of City of London's practice. And I've seen that in evidence, I've seen it in the data, the case studies. So people remain at the centre. What they wish to happen must be and is clarified when those initial conversations are happening. People's mental capacity is taken into account, undue pressure, coercion, etc. So there's lots of skills that the workforce have to work with people to make sure they stay in control and that they are at the centre of any decisions that are happening. And that's absolutely critical in our community engagement strategy.
Thank you. Chris?
Thank you very much indeed, Chair, and thank you for your presentation and for the report. I agree with Deborah that it was a really good report. It was really well written. It wasn't too long, neither was it too short, so I was really pleased with that. And it allowed me to ask myself a few questions, which I can now ask you. And please do forgive me. I'm going to ask you questions about things which actually look good in the report, just to challenge and to see if you are confident that they really reflect the reality of the situation. The first is to do with the complaints that have been which have been followed up, and the significant fall there has been in the last year from for complaints to do with service providers. And I'd just like your feeling as to how we can be sure that that is a reflection of better practice and is not merely a case of concerns not ending up being reported at all. And I don't know if these figures also include individuals from the City of London who are given places in care homes which are outside the city. I don't know if they would be covered by the safeguarding figures that we've got here. But with what's happened at a national level in in a number of care homes, been very well publicised, I am always concerned about the possibility that something is going wrong in a care home and is remaining quiet. Now, I don't know if that is covered in your work because some of the care homes may well be outside the city and Hackney. Exactly. So I'm not sure about Hackney though. They may be within Hackney, so. Are care homes covered for residents from the city, even if they're not, the care homes aren't in the city? And are you satisfied with that apparent good news that the percentage of referrals to do with service providers has fallen? That's my first question. And the second also to do with the statistics. I'm very well aware, not from the city, but from Cambridgeshire where I live and where I'm a councillor, I'm very well aware of the distressing situations which exist with deprivation of liberty. And there are all sorts of dreadful positions that people find themselves in where there is ultimately little choice but to deprive them of their liberty. And it's a very difficult decision to make, to be quite honest. It's a fundamentally wrong thing to do. And there are safeguards in place, including individuals who are advocates for those who've had their liberty deprived, to try to make sure that their rights are upheld as well as possible, whilst accepting that in some cases, unfortunately, it is the best option for those individuals.
Mm-hmm.
And it was the statistics which got me here, because you very kindly, of course, with it being City and Hackney, you provide us both with numbers for the City and numbers for Hackney. And not surprisingly, the numbers for Hackney are massively larger than for the City for very obvious reasons. What I found really interesting was in the Hackney statistics of those applications that were over the last 3 years. In round figures, 1,700 were authorised, 200 were not granted, and 800 were withdrawn. So about 40% either weren't granted or were withdrawn. In the City, the figure was 0%. Now, I know we've got a much smaller base of only about 100 cases, but to have had no applications not granted and to have no applications withdrawn could either be shown to show how well we are doing in processing it originally, or it could show that we're failing to give the safeguards that are being given in Hackney. So I just wonder if you care to discuss those two apparently good statistics that we've got in the report for the City. Thank you.
Thank you very much. I'll start with the deprivation of liberty safeguards, if I may, because it's fresh in my head. So I think the first thing to say is that there is no backlog in the City of London in relation to deprivation of liberty safeguard applications. And again, that's a very, very strong position for the reasons that you've outlined. You know, an unlawful deprivation of somebody's liberty is illegal and brings with it huge risks to the person and also to the local authority in terms of reputational and financial damage, but the person must be at the centre. So in terms of City of London's figures compared to Hackney, and again, Chris may wish to come in here, but my understanding of that would be attributed to that you don't have the same number of people in terms of the care homes and also hospital admissions and discharges. So when people go into hospital, so the number across the Hackney examples that you gave, a lot of that will be attributed to people who have gone into hospital, a DOLS application has been submitted, and then they've sadly passed away or they've been discharged and the DOLS is no longer required. So that might be a very different position in terms of City of London, given the positioning in terms of the hospital, etc. The other part of that in relation to the quality assurance, so as an incoming chair, I haven't looked into the quality assurance of the DOLS assessments within City of London, but the procedure that will be in place to give assurance will be that a best interest assessor will carry out a number of assessments, make sure that the adult is supported to convey their views on the deprivation. You know, there's lots of legal tests that need to be met, and then somebody within City of London, separate from that assessor, who for all intents and purposes is an independent assessor, will authorise it. Excuse me. So they'll go through and check that everything is as it should be. Because I don't know if you want to come in, because you'll be closer to the detail than me in terms of the DOLS.
If I may, Chair, yeah, thank you, Claire. Just I'll bring Ian in, who's Head of Adult Social Care, in terms of some of the points you were making there around process, just so members are aware. So I act as the authoriser here in my capacity as Director of People, and all the points that Claire makes are absolutely valid and right in the context of the City of London. And I am checking all of the paperwork that has to come to me in terms of the best interest assessor, any psychiatric assessments, etc. I would be going through those in detail, and I have to authorise on the basis that I am satisfied that they've met all the legal tests in terms of the submission. So that's I'm the end point in the process, but there's a lot going on beforehand. We don't have a backlog. We don't have any. I don't think we've had any out of date. And it is tied up with the numbers. I appreciate that our numbers are obviously much smaller, but also our best interest assessment process, I think, is robust in terms of the way that we utilise and commission that service. I'll bring Ian in, who oversees the operational side of it.
Yeah, thanks. Yeah, just to assure you that all our assessments are done by independent people. So we commission our spot purchase this best interest assessors, and we spot purchase mental health professionals to to do the mental health assessment, and then we bring it in where we've got skilled and trained people, best interest assessors, to then review it and go through the process before it even gets to Chris. So there are processes in place and safeguards. But also the other point I'd like to make, it's not just that we don't have a backlog, we are proactive. We go out and we think that it's a deprivation of liberty. We are out in the care home saying we need to do a deprivation of liberty. We don't sit there waiting for them to contact us, which other local authorities do because of the backlog. So we are very proactive, and we're very confident that all the people that are deprived of their liberties we are aware of, and they're lawfully deprived of their liberties through due process.
Thank you. Thank you. And then the second question in relation to the care homes that are out of City of London. So those safeguarding concerns and inquiries would not be reflected in the City of London numbers. And that's because the way that it works is it's where the abuse or neglect is alleged to have taken place will lead on the safeguarding inquiry. So if it's another London borough, they will lead, and those figures would be included in their statistics in relation to concerns, and section 42 is complete. Now, that's not to say, and again, Ian and Chris have got the operational detail here, but from my experience in other areas, City of London staff will be very, very front and centre involved where safeguarding concerns are raised, and the resident is a City of London resident living in an out of area placement. And there's lots of systems, processes, checks and balances in place around being proactive. So making sure that your annual reviews are up to date, that people have access to the right advocacy, that the quality assurance systems are robust. And as an incoming chair, these are some of the questions that I'm asking in the, and they're being welcomed and they're being well received in the City of London subcommittee. So within our dashboard that we present in the City of London subcommittee, which is a subcommittee of the wider safeguarding board, these are some of the questions about out of borough placements I'm asking as an incoming chair. And I'm being provided with that assurance, but again, it's early days for me to provide a full answer there. And I think the same would go in terms of the service provider complaints reducing. Again, it's too early for me to comment on that at this stage, but these are the questions that I'm asking as well. But again, I don't know if Chris or Ian wish to come in and provide extra information.
Yes, thank you. Just to say that what we do in the city, which I don't think a lot of other local authorities do, is we actually record all safeguarding concerns in the same way that we would record our own concerns inside the city. So we do have them. They're not included in that data, but they are included in the data that we look at in our performance data, and they're interrogated from that perspective. Also, we work very closely with our colleagues in commissioning. So when there are issues we go out with commissioning, we can do joint reviews, joint visits, and also work in partnership with other local authorities.
Thank you. I'm still quite intrigued by the disparity between the Hackney figures and the City of London figures, not in terms of the actual gross numbers, which are obviously going to be very different, but in terms of that percentage of those DOLS referrals which are either not granted or are withdrawn. Would I be right in thinking that the City of London actually has greater resources which it puts in per referral? We are spending significantly more in terms of each potential referral, which is why we end up with zero not being granted and zero not being withdrawn. And I'm not trying to get at Hackney here. I'm just trying still to understand how we can end up with that 0% when Hackney is at 40%.
I'm not sorry.
Oh, sorry, no, Ian, I was just going to say, I think that the number, if you want to come after me, Ian, please do. Just very briefly to say that Hackney it don't have the waiting list for dolls either, and the numbers are somebody's carried out an assessment and they may get parts through the assessments, and sadly somebody has died or they're discharged. So it isn't necessarily a negative figure, or it could be they don't meet the criteria, so they have mental capacity, or actually their care and support arrangements don't equate to deprivation of liberty. So there's lots of reasons that things will not be granted or they're withdrawn. But Ian, apologies, you may wish to come in there.
I totally agree with that, and as well the comment about that Claire made about hospitals. I think with larger numbers, you're going to get more people in hospitals, and so you're going to get more that actually don't follow through. And whereas our figures are not always 100%, they are at this time, but they're not always 100% because there will be people in hospitals, for example, that happens too. In terms of the extra resources, I think it may be more that we've got when we do place people in residential placements outside the city, we're looking for things that suit that person. So they're often near relatives, they're often in different provisions, whereas some in other local authorities, they may have more sort of block booked accommodation. So ours are kind of more driven, I suppose, by choice. That's not to put down other local authorities. I just think that the way that we work is very sort of person centred.
Thank you. Steve.
Do these figures include self-funders?
If there are any self-funders in the city where a safeguarding adult concern is referred, it comes to us as well. It's just a legal responsibility within the City of London, so they would have to be referred to us. But anything that's referred to us, it doesn't matter who commissions the service, even if they've got a service at all. It doesn't matter if they've got care and support needs and they're a victim of abuse and they're referred. We know about them, then we have a responsibility to respond.
Because my wife was a self-funder, and when she went into a care home, I know it's a long time ago, but the city weren't really involved, so you wouldn't necessarily have known.
Sorry, that's correct. If it's a self-funder in another local authority area, then we have absolutely no jurisdiction. It's legally responsible to the local authority.
Liz.
Thank you. Mine goes back around to the beginning, noting that so much of the safeguarding risk is around people in their own homes. And we've discussed engagement. And you mentioned, how do we reach the unheard voices? What is your strategy on that? Because, you know, Health Watch is one thing, and people who engage, I mean, the unpaid carers are a great place to go because they're just embedded in the community, but there's a lot of people who go under the radar.
Yes, thank you very much. Really important question. So in our strategic plan, the first objective is safeguarding is everybody's business. So it's about making sure that communities, so residents who may have no contact with any services, or maybe just a GP or health services, but have no contact with statutory services, understand what abuse and neglect is and how to report it, and the earlier point about what happens next. In addition to that, there's really important work underway. So national analysis has shown us that there is still work to do in the safeguarding adult space in relation to cultural capability. So understanding within different communities, and then there are communities within communities, what those different beliefs, culture, religion, you know, the impact that can have on people's recognition of abuse or understanding what happens next or what they would like to happen next. So there's lots of work that we're doing as a Safeguarding Adult Board, as I said, to build on existing pathways, to make sure that everybody, so something I often say is every contact counts. So every contact you have with somebody, it doesn't matter what your role is. We all need to know what abuse is, abuse and neglect, how to report it and what happens next. So our community engagement strategy, those three core elements run through it really, really strongly. But to get those messages to people, it's about the workforce, making sure everybody's done their basic awareness training on safeguarding adults, making sure that the community, voluntary and faith sector have done basic awareness training, that there is information shared in a way that's accessible to people. So taking into account digital exclusion, languages, in ways that people can understand, not using jargon, because safeguarding is a word, but it means lots of different things to different people. So clear messaging, those three core messages, using safeguarding champions who already have trust with communities and who may have contact that none of us will. Those are the fundamental principles of the community engagement strategy. And again, I've been here since June. I'm connecting with people, and as I say, I've got a meeting coming up with the lead from the voluntary sector following the joint meeting with the Health and Wellbeing Boards last week, because they're the experts in this space, and I need to build those relationships and trust with them to deliver those messages, but to receive messages back as well. So there is lots to do in this space. The other really important part of this, which I think, you know, and is a significant issue for City and Hackney, is social isolation. So connecting people to things that are important to them and people that are important to them. We know social isolation is a major factor in terms of increased vulnerability and therefore potentially somebody being vulnerable to abuse and neglect. So those social connections are part of our community engagement strategy as well.
Thank you. Please.
And I'll just say, I think elected members are probably who live in the city. Mm-hmm. Everyone in Aldersgate, everyone in Cripplegate, and some of Portsoken all live in their communities and see people all the time. I probably know more volunteers across the city than anyone. I have no idea who the city's lead volunteer person is. So I'm not sure how close they are to people who are, you know, running neighborhood watch on Middlesex Street and things like that. So I think there's a lot of knowledge that we bring. Mm-hmm. And just because we know people, and a lot of us are very old and have lived here a very long time and are involved in things. So I would recommend that route too, but some outreach to the members just so we know what to do and how to direct people who come to us with concerns, as Deborah mentioned about your neighbor was worried about a friend. And these are things that come to us, and some training for us would be quite useful in this, I think.
Thank you, absolutely. And as part of the Safeguarding Adult Board's assurance, and again, I think this is work that we will continue to develop, and I'm learning what this looks like at the moment, is the training offer in relation to adult safeguarding. So, you know, focusing on City of London today, I guess the question is there training available for elected members around basic awareness of safeguarding adults? There may be, for some areas have it for children and not for adults, some have it for both. So that would be a really helpful starting point. I'm really happy to lean in and support with anything that's required.
Thank you very much, Claire. If there's no other questions or comments, thank you for coming along this morning and presenting. And it's been very helpful. Thank you.
Thank you very much. Good morning to everyone. Thanks.
Clark?
Yeah, so sorry, I was just getting the slides up. So our next item is item 5, which is the NHS ICB operating model. And we have Amy, who's joined us to talk to that.
Welcome, Amy.
Thank you. Okay, shall I just go ahead?
Yes, please.
Great. Okay, so I'm Amy Wilkinson. I am the City and Hackney Place Director for NHS North East London ICB. We've got a couple of slides for you today, and I'm conscious that the item was requesting an update around the new ICB operating model. So there are some things that we know about what that is and what that will look like, and there are some things that we don't. So hopefully we can be clear about that, and I will endeavour to answer any questions that you've got as much as we can. So you'll be conscious following the March announcements of a 50% reduction in programme and running costs for all ICBs. The North East London NHS proposed a new operating model to NHS England, which has been agreed. We don't know what that looks like yet as staff, that it's not been publicly announced, and you'll be aware of the kind of national conversations in the background around how redundancies could potentially be funded. And so we are essentially waiting for agreement on that. So agreement by the Treasury before the ICB can announce what the new operating model will be and what the effect this will be on staff. So that's the bit that we don't know. Initially, you'll be aware that the reductions were supposed to be actioned by December 2025. We are clear that that's not realistic any longer. I think the earliest we would probably see any kind of compulsory redundancies would be April, part of the next financial year, although that's a bit of guesswork there. There are really clear lines. Oh, next slide, please. There are really clear lines about what the functions of the ICB will be going forward. So there's a role around being strategic commissioners. There'll be a 4 workstream model, and there's a big focus around evidence-based commissioning, so public health, population management approach, and looking at a population lens for our commissioning. Their guidance quite clearly states that there is a role for place partnerships. We don't know what this will look like. We had the first meeting of the joint City Health and Wellbeing Board, the Hackney Health and Wellbeing Board, and the City and Hackney Health and Care Board last week, which was really useful in terms of developing some of those relationships. But I think it's probably fair to say that there will be quite a strong role for health and wellbeing boards into the future. We are less clear about what, if there will be a role for health and care boards. So thinking locally about what we could propose around those ways of working. There is a really clear narrative around neighbourhood working. You'll know that this has come out in all of the national guidance as well. So again, for the City of London, I think there's an opportunity to think about what will this be, how can we make this work for the city, and what is useful. Okay, next slide, please.
Sorry, I'm doing my best.
Okay, no problem. So what we've been working on in terms of the ICB for the last little while is what we're being tasked to do by NHS England. And those things are around developing commissioning intentions. So strengthening that focus as strategic commissioners. So developing finalised commissioning intentions by December. Developing a 5-year strategy and a delivery plan. Again, the timescale for that is for December. We also do need to develop a 1-year place or integrated delivery plan, and there's very little guidance around what that will look like. So we're in a bit of a holding pattern for that. And we will, when the time is right, begin to implement the new ICB operating model. We don't know anything further on the timescales for that. So the final slide is what we do, what the ICB have said around what we know will be different about the future and what the responsibilities, how they will land. So looking at ICB responsibilities being around ambition, strategies for neighbourhood working, leading development of supporting resources, lots of acronyms there, INTs are integrated neighbourhood teams, population health management, workforce, looking at provider work, links with providers. There will be a regional body who's doing provider performance monitoring and looking at best practice. And then what they envisage will still sit at place with a very small place team is around relationships across systems, partnerships, of which we have well embedded partnerships across City and Hackney, local plans, work with populations, co-production and engagement activities, and resident voice. And this is one of the areas that we focused on at the joint meeting last week. We've been really lucky in terms of what we've been able to do, and you'll be aware of the conversations around Health Watch. So the Health Watches and the direction of travel for them. It will take statutory changes to legislation to enact the end of Health Watches. So there's looking at potentially 2027 for that. Places will also look at alignment around neighbourhood working and improving quality locally. So that's the end of the slides, and I will leave it there. I think the key thing is that there will be a new operating model. It is almost ready to go, but we can't share that publicly as yet. And it all sits within kind of quite a lot of changing landscape. But locally, we have strong partnership and strong governance in the health and wellbeing boards and the ways that we work. So thinking about what we want to retain at place going forward. Back to you.
Thank you, Amy. if I can kick the questions off, I mean, how are the financial constraints and proposed cuts at the ICB level affecting the current services delivery and commissioning decisions for our city residents? And what do you think the likely impact for the future?
So nothing has been enacted so far. So we shouldn't be feeling an impact as yet. One of the things to hold on to, and I think I might have said this to this committee before, is that there are no proposed cuts to commissioning budgets. So generally, we are anticipating that there won't be huge changes to what is currently provided for residents in terms of what is commissioned. The changes are to the core staff members, so those commissioners, so streamlining that. I think, yeah, that there's potentially a need to make sure that we have a really strong city voice going forward in the commissioning, and to do some thinking about how we propose that, but no immediate impact on service delivery.
Okay, thank you, Amy. Deborah?
Yes, thanks, Amy. That was actually very helpful, and I'm not quite sure whether this question is appropriate for you or not. So please boot it back at me if it isn't. It's really about the place and the city being so unique. And I'm on the Planning and Transportation Committee, and I'm just very aware that the Planning Committee is approving, for obviously reasons for growth and creating jobs, more and more large office spaces with more and more city workers. So we're boosting the numbers of people coming into the city, and also the sort of the nighttime economy. We've got all of the office cleaners, the security people working here as well. And we're also giving approval to more sort of hotels actually in the city. So I'm just thinking that the kind of place is changing, and I'm not really sure whether strategically we are making sure that our primary care in particular is actually gearing up for the kind of strategic changes to the workforce numbers and the kind of and particularly for the nighttime people as well. So I'm just wondering whether we're looking ahead enough. But that's about, apologies if this isn't relevant to you or not.
I think it's a really good point. And I think primary care colleagues have potentially been to this meeting before, and that is definitely a question for them. For quite some time, primary care has been commissioned centrally, so at North East London. That will continue, and the commissioning arrangements won't change. In terms of that, we do have some support dedicated to City and Hackney, and I think part of that should be sufficiency and horizon scanning and looking at change with a focus on population health management and being a lot more data led in the commissioning. I think that should help, and that should respond to your point about horizon scanning and changing. But I think in terms of a primary care approach, I would suggest that we bring colleagues back to talk about that.
Thank you. Chris?
Thank you, Chair. Forgive me for being cynical, but it seems to me that the goals which you have mentioned, that, for example, moving from hospital care to home care, moving from treatment to prevention, this is very far from new. We've been talking about this for 5, 10, even 15 years. And it seems to me, certainly on the treatment to prevention shift, that without significant resource reallocation, that is not going to happen. And it hasn't happened significantly, it seems to me, over the last 10 or 15 years. Now, I could be wrong. You might tell me that I'm not noticing what change there has been. But would I be correct to have some degree of cynicism to say this is not new, and what is new about the approach now, which will achieve results which haven't been so far achieved over the last 10, 15 years?
I think that's a very good question. It's very relevant. We got some medium-term planning guidance out yesterday or the day before yesterday from the NHS, and some of the key strands that they were focusing around prevention were around obesity and healthy weight, those factors that would affect long-term conditions, and lots of stuff around digital and how people manage long-term conditions and use what's at their disposal to do that. So that seems to be the direction of travel in terms of the NHS work. In terms of North East London, they've developed a prevention strategy, which is new. There locally for City and Hackney, we've got quite a strong focus of trialing work around prevention and plans. I think probably less of a strong track record around actually implementing work on prevention. So there is a prevention investment standard, which is some funding allocated to pilot some pieces of work over the next few years that we will continue to be able to deliver. Because there are not cuts to those budgets, we will still continue to do that. But I think you're absolutely right. The really big question is, can we, and what levers do we have to move some of that funding from the big acutes and from the response and the treatment back downstream into prevention? And I think that conversation needs to be had, and I can't give you assurances around that key point.
I'd like to thank you for the honesty of that response, and it does, I have to say, reflect what I have been seeing. The last time I saw any numbers about this on a national basis, the amount of the NHS budget which effectively went to primary care was 8%. And I think it's widely recognised that any prevention mechanism has to be largely based at primary care level. So until we have that shift of resource, quite apart from needing the change in organisation as well, but until we have that shift in resource, we're not going to achieve the aim. And maybe I was being optimistic to hope that you would say how that shift in resource was going to take place. But it seems to me that the acute sector is much more voluble in terms of protecting themselves. They've got much better publicity. They're the ones who appear on television all of the time, and primary care doesn't get a look in as far as that's concerned. And there needs to be a mechanism in place, and it doesn't come from our local area. It needs to come nationally, of actually shifting those resources. And I'd love to see that happen.
I think what we could do is have a look at what is articulated in the medium-term plan. There are some really tight financial controls on the acutes now that are new, and still working through exactly what that will look like. Henry Black, the finance officer, was talking a bit about that yesterday. So I think conversations are happening. I can't be clearer, unfortunately, about any timescales or what this might look like, but I'm really happy to also to bring primary care colleagues back as well and get their view on that.
Is there any other questions or comments anybody wants to raise? In that case, thank you very much, Amy. Thank you for attending this.
You're welcome. Goodbye.
Thank you.
Okay, so item 6, dementia services. We're expecting Emma to join very, very shortly. I don't know if you want to move to. Oh, okay, all right. Or do you want to switch to item 7 and then?
She said she'd join at 12.
Okay, 1 minute.
Excuse me, Chair, could I just maybe make the point to the clerk that it would have been helpful to have those slides in advance, and I don't really know whether again, yeah, but it would.
We did actually get them quite late, but I will forward it to you right now.
And similarly, if this presentation had been available.
I haven't seen that at all.
Last presentation, with respect, we could have just used the slides from 3 or 4 years ago.
Yeah. I mean, we do make an effort to try and get the slides up front so people can look at them, but yeah.
That issue of primary care money that is not a local issue which can be sorted out. Government has to put the change in money. I'm not even saying extra money, but the change in resource has to come from central government.
Good morning. Thank you for joining us, Emma.
Hello, Emma.
Hi, thank you.
Over to you.
Oh, okay.
Did you have a presentation you wanted to share?
Yes, I have to work out how to do that.
All right.
Okay. Sorry, I'm just getting muddled with my screens here. Is that sharing? No.
Yeah, we can see that. Yep. That's fine. Thank you.
Is it the presentation? Yeah. Yeah.
Yes.
Yeah.
Great. Okay. So I think Dr. Knowles and Adenike are going to join as well, but I told them to join at 10. So yeah. So I'm Dr. Emma Tepp. I'm the psychiatrist in the City and Hackney Dementia Service. And as I said, we have a GP, Dr. Knowles, who's GP with special interest, and Adenike is a service lead. So the model we have of the dementia service in City Hackney is that we accept anyone from GP or hospitals for assessment of any age, obviously over 18, and then once we assess, and if we diagnose with dementia, we then don't discharge them but hold them in the dementia service until they either die or move out of borough. So essentially the dementia service is two teams. We have an assessment part of the service, and which does assessment and diagnosis, which is consultant led, and then the post-diagnostic follow-up and team is nurse led. So each patient who has a diagnosis of dementia is transferred from the assessment part of the service to the post-diagnostic team, and they will have a named nurse or dementia navigator for ongoing support around their dementia to themselves and their carers and family. So so we divide the dementia service into neighbourhoods. So each part is comprised of two neighbourhoods comprising a nurse and a navigator, and they support the GPs and the care homes within their neighbourhoods. The whole of the service currently holds 936 patients across City and Hackney, 26 of which are definitely City in the Neiman practice. So as I said, we accept anyone referrals for anyone with a suspected dementia across City and Hackney, and we receive the referrals from the GPs, from the Homerton, and from specialist clinics such as the Parkinson's Clinic at the Homerton, but obviously we'd accept from Royal London, anywhere else that refers to us. So all our referrals come in through the single point of entry and are discussed on a Tuesday morning with the wider team, including the community mental health team, and to allocate to either the community mental health team or the diagnostic or dementia service. They're then assessed, and then once diagnosed with dementia, as I said, transferred to the dementia post-service diagnostic team. And at the end, I've got a much more detailed slide, but essentially, sorry, I hope that's clear, but the referrals come to the SPE, then they're either diagnosed for assessment if there's cognitive problems, so they have assessment and one scan, can be referred on for more specialist tests with neuropsychology, or we'll also refer to neurology, and then they're either discharged with no diagnosis of dementia or mild cognitive impairment, or we diagnose with mild cognitive impairment and we might recall them after a year, or they're diagnosed with dementia and transferred to the dementia service, where they'll be followed up, as I said, by a nurse or navigator. But if things deteriorate, if they have significantly worse, if their symptoms of their dementia worsens, we transfer to the community mental health team, who then manage until more stable and will transfer back to us. So the post-diagnostic support, we have a dementia nurse who will visit within 6 weeks after the diagnosis, and they will titrate the medication, sort out any other problems, do advanced care planning with them. Once things seem stable, they are then stepped down to dementia navigator, who will visit a minimum, hopefully, of every 6 months. We also offer cognitive stimulation therapy, which is an once a week, 8-week course at Felstead Street, which helps patients to improve, develop memory strategies. We have a carers session in that as well, and people really enjoy that because, you know, it's a group and they get to meet other people. We also provide transport to that, which is unusual for that type of service. In addition, there's Singing for the Brain, which anyone can with a diagnosis of dementia can drop into at the Pembury Centre once a week. It's in Dalston. There's the City Memory Group, which people can also access if they live in the city. We also run a carers group where there's educational sessions that runs for a few sessions every so often. And then there's also a mild cognitive impairment group for people being diagnosed with MCI and give education around that. And that's again, once a week for several sessions. So in terms of the rates of dementia, so in England, as last month, there was 66.3% of people had a recorded diagnosis of dementia. And in City and Hackney, we have a dementia rate of 68.5%. Who have a recorded diagnosis, which is higher than the England average and the national target of 66.7%. So the prevalence of dementia is on the increase, and on the 30th September we had 1,494 people were estimated to have dementia, but compared with the estimated prevalence is currently 1,538 this year. The rate in the city, unfortunately, doesn't seem to be as good as our overall rate in Hackney. We only have 36% of patients. Our diagnostic rate is only 36% compared to 71% in Hackney. So in the city, we appear to be missing 64% of the patients. So they estimated number of people with the city.
Can I just stop you there, please?
Yeah.
There's a couple of members that'd like just to make some comments. Are you happy to take them as you at this point?
Yeah.
Thank you.
I do apologise for interrupting, but I could see that Liz had exactly the same question that I had on those numbers. To have and maybe it's because we've both misunderstood, because to say that 66.3% of over 65s are diagnosed with dementia.
Sorry.
Then could you explain what the numbers mean, please? Sorry.
Sorry. I'll just go back if I can work. Oh, sorry, have I just done the wrong screen totally? Let me just go back.
Thank you.
No, that's forward. I don't know if I can work out how to go back. Previous. So this is an NHS England work out how many people they think in the country should have dementia, and then they work out, so they base it on their statistics on how many people they think should have a diagnosis of dementia, and then they look at how many people who actually have a diagnosis of dementia, and they work out that dementia rate. So these figures show that in England, of the number of people that they think should have a dementia diagnosis, 66.3% have a dementia diagnosis. Does that make sense?
Yes, it's not what the slide says, but what you're saying makes sense.
I think so. It's saying 510,000 patients in England have a recorded diagnosis of dementia, which is 66% of the expected number that have a diagnosis.
And that's what wasn't clear, that it was that percentage of the expected number. Thank you.
Sorry, apologies. So in City, as I said, the diagnostic rate is 36% of the number that they think should have a diagnosis. So they think there should be 88 people in the city with an estimated they've estimated that 88 people in the city should have a dementia diagnosis, and in Hackney they've estimated 1,449. But obviously in the city we only have 36% of that, as I said. So in the last
Emma, can I just ask, going back to those figures, they're very low in the city. What can be done to increase that?
So I'm going to come on to that if that's okay, as to what.
Apologies.
Yeah. So in the last 3 years, last 3 years, you can see. Sorry.
Sorry, Emma. I was just going to say as well. you're only looking at referrals there from the Neiman practice, but some city patients are registered with Tower Hamlets practices, so it's not an overall picture of the
most of the patients registered with Tower Hamlets practices go to Tower Hamlets, so they don't come to the city. So yeah, you're right, we haven't got the numbers, we've only got the well, so the NHS England figures cover the whole of city, it doesn't matter what practice they're in. So, but you're right, it could be that some of those people aren't being captured by the NHS England data. So in the last 3 years, these are the number of referrals we've had from, as I said, the Neiman practice. We occasionally have a few other referrals from other practices, but we're talking 1 or 2 a year. Very, very small numbers because, as you said, they go to Tower Hamlets, not to us. So not a huge number of patients diagnosed dementia or MCI in the last 3 years. So why is there such a big discrepancy? So is it because patients we've thought long and hard about this, because obviously the numbers in the city are very different to the numbers in Hackney. So is it because they're being under referred in general, or are they being referred elsewhere? So so that could be one reason. Is the estimated prevalence of 88 patients, is that actually correct? And our feelings are with that, and we've discussed this with the Neiman practice as well, there's very high level of socioeconomic status on the whole in the city, higher level of education and neuroprotective. So is it possible that city residents aren't actually developing dementia or developing later than we'd expect them to? Are they being diagnosed elsewhere and they're not coded on the EMIS or coded in the GP practices correctly? And as I said, are they being seen elsewhere? Are they accessing private care, not registered or using the NHS service? So there's a few different reasons we think why that number's lower. So what we've done so far is we've discussed with the Neiman practice to encourage referrals, and we've gone through our lists and checked them that our dementia list is the same as their dementia list, and we've checked patients are correctly coded and where they've been, and sometimes they're not coded as dementia when it's a different type of dementia, so we've taken steps to improve that as well. So moving on to the Dementia Alliance, this is a alliance set up in City and Hackney. It involves statutory and third sector partners in the city, and Hackney are involved in dementia diagnosis and care, and also has older people's representation. It brings system partners together to improve services for people living with dementia and their carers, advocates for people with dementia to ensure high standards of care. It's chaired by a GP and meets bi-monthly, and do implement different projects, including, for example, Dementia Champions and Dementia Information Posters for GP surgeries, which aims to improve diagnosis and care. So challenges for our service in general, we want to encourage the number of referrals we receive, but obviously that means that the more patients we have referred, the more we obviously have to see, so that does affect the waiting times, and unfortunately currently our wait time for a new assessment about 3 months. We also struggle sometimes with timely access to investigations. We send all our investigations to the Homerton. For CT scans we can get them within about 2 weeks, but MR scans taking between 6 and 8 weeks normally. So we want to also increase the number of diagnosis of dementia to find all those people that we haven't diagnosed so far, but without compromising the quality of our post-diagnostic support. And then obviously in the future, as a system-wide, nationwide challenges are these new treatments that are coming through the pipeline if they ever get approved by NICE, but that will completely change how and the speed and how we do our diagnosis. Yeah, and that's I hope, and that this is the very complicated slide of our service. So I think I've covered most of that in the talk, but if there's any questions you have or anything else, also Adenike and Rob also here to answer.
Okay, well, thank you, Emma, and sorry for the interruption, sort of mid-flow, but it was just relevant at the time of that. Just going back to the Neiman practice, I mean, I'm led to believe that they say a lot of people just don't want a diagnosis. I mean, why would that be the case?
I mean, I think there's lots of reasons why people don't want a diagnosis. Sometimes people don't feel there's anything that can be done, which we could argue about. Sometimes, obviously, they don't want to know. People just don't want to know if they've got dementia. And if their family agree with them and they're managing, then there's an argument to be said, does it, you know, it's up to them, isn't it, really? So we would say with the right diagnosis and the right support, you can have a better quality of life with that, and it prevents lots of it can help prevent the post-diagnostic support. We hope can prevent crisis and can put in good care planning and mean that people can live as well as they can for as long as they can. But we do have pre-diagnostic support from the dementia navigators if people are unsure, they want to know more, they're scared of, you know, going. So we do offer that as well, which, you know, people can refer to us just for the pre-diagnostic support before coming near a doctor or getting a diagnosis. Does that answer the question?
Yes, thank you, Chris.
Sorry,
sorry.
I don't know whether you saw my hand, Emma. Thank you.
Apologies. You're right at the bottom of the screen, so apologies for that.
It's okay. I mean, I just want to echo what Emma just said in terms of navigator support, especially for patients that are unwilling to engage with the diagnostic process. The dementia navigators are able to support and encourage that process. One other thing that we do that we haven't, which Emma hasn't mentioned, is all the patients that has a dementia diagnosis have urgent care plan created at the point of having the diagnosis, so that should they come in contact with emergency services, they can easily be supported in the community, at least with all the relevant information, which are co-produced if they have the capacity to engage in the process. That's what I want to add. Thanks.
Thank you. Did you want to say?
My question. Thank you.
Chris. Sorry. Please.
Emma, it's Chris Lovett from Public Health. Thanks very much for the presentation. Just wanted to confirm, in Tower Hamlets, I think ELPT is the provider of the dementia services.
Yeah.
So in relation to answering that question of people who are registered with a Tower Hamlets practice, of which the Goodmans Fields, I think, would be the majority, not the only, but the majority, it should be relatively straightforward for you to be able to query the patients attending the health memory services in Tower Hamlets, and then just be able to pose off that question about how many people who are residents in the city are not actually in that percentage calculation.
Well, we'd have to know, because how many patients who live in the city are actually registered with a Tower Hamlet practice. So that would be a Tower Hamlets question, I guess. But it should, because I think, if I'm not mistaken, the dementia diagnosis rate, that's done on local authorities. So it's done with the number of patients. But yeah, I don't know whether they work it out per GP practice or whether it's. Do you know, Adenike, whether it's, because if it's done on address or GP practice, but I think it's done, they get their data from EMIS, from the NHS England get their data from EMIS. So I'm not quite sure what happens if you live in the city but have a Tower Hamlets practice. So I can't answer that, but you might be right, some of them, but I don't think it's a huge number that are living in the city going to Tower Hamlets. That's not the impression I get, but I can't give you definite figures on that.
Yeah, I feel like sorry, I'm Rob, by the way. I'm a GP special interest dementia at the City and Hackney Dementia Clinic. I was just thinking on that, they probably would have by borough, wouldn't they, how many patients are diagnosed? So we could marry up the two figures, and once we had that, you know, how close is that to the, you know, missing 64%, and is that some of the gap? So I think maybe we could liaise with Tower Hamlets to get that figure for City that I'm sure they would have by borough, and then we could marry those two together.
Right, thank you very much indeed. I wasn't very satisfied by these statistics which were given to us, but I understand where the 64% shortfall is, why it's been presented to us. but the proportion of city residents who are registered in Tower Hamlets is quite significant. It's not a majority, far from it, but it's nevertheless quite significant and will be 20%, I'm told. So that will provide a significant proportion of that 64% missing number. And these numbers are not difficult to find. The one thing NHS is pretty good at, it's getting statistics and using statistics. And I'm sure that within the NHS and local authority ecosystem, these statistics should be fairly easily available. What's also the case is that the city has an unusually large number of individuals who are registered well outside the city and Tower Hamlets. So I haven't got a percentage for that, and that may be more difficult to find, but I'm well aware, and I see some nods from the resident members sitting opposite, that we do have quite a number of our residents who are not locally registered with GPs, but have GPs in Westminster or beyond, or have virtual GPs. So I think that can be found and can be looked at and can reduce your 64% significantly. The second thing which can reduce the 64%, which was mentioned and again can be quantified, I'm sure, is the socioeconomic makeup of the Neiman practice in particular. And if we look at that, we're talking about 2 lower super output areas, which the Neiman practice basically covers. And this is out of 22,500 lower super output areas in the country as a whole. And in the last figures which are available, the index of multiple deprivation from 2019, in those one of those 2 lower super output areas in the city was the least deprived of the whole 22,500. Now, there are different ways of measuring. I don't even want to go into the 7 different mechanisms which are used to make up the index, but nevertheless, it is an extreme case in the city of lack of deprivation, as is measured by the IMD. And again, there must be statistics available at national level of the correlation between deprivation and the incidents which take place as far as mental health is concerned generally, and of this in particular. So I really think that information should be and is available, and it would be really useful, because if you're chasing a 64%, which is a mirage, then you're actually not necessarily concentrating on what needs to be concentrated on. I think getting that 64% analysed down, using those 2 indicators in particular, I think would be really useful to focus on what the problem actually is. There was one thing which I didn't fully understand. The navigators, I'd be really interested to hear a little bit more about the navigators and what they do. I take it that they are NHS funded entirely, and I'm assuming that they perform a health function rather than a social care function. But those are big assumptions. I'm pretty sure there's no Section 75 agreement in place between the local authority and the NHS on this. But what are the navigators? What do they do? And do they fulfil a health function?
Do you want me to answer that?
Yeah.
Okay. So the navigators are employed by ELFT, and they are Band 4 staff, which means they are not really clinicians, but they provide support in terms of monitoring. So they will go in every 6 months to see how patients and carers are coping with dementia. If there are any safeguarding concerns that are come to attention, they will make a referral to adult social care for adult social care to do the assessment and put support plan in place. They would assess to see if there's any risk that needs to be followed. And so they are kind of monitoring. They can signpost as well to any services that they think might support persons with dementia in the community. For example, Acne Caribbean organization, for instance, anything that can promote integration, prevent social isolation, and make people to live well with dementia. So they have a high caseload of about 100 people, depending on how well the patient is in the community. And then they can step up a patient to a nurse, for instance, if the impression that the patient is becoming unwell, if there's anything that has to do with medication management, they might step a patient up to a nurse. We have an MDT meeting every Tuesdays whereby we discuss complex cases, and we can decide whether a patient needs to be stepped up to a nurse or we need to step a patient up to a CMHT. I hope that answers your question. And of course, the post-diagnostic or pre-diagnostic support as well. They work with it. They can go to GP practices to engage patients that may benefit from a referral, but are not engaging with the GPs. So there is no Section 75 agreement involved in our service because we don't have an allocated social workers, and the navigators are not qualified social workers, but they have enough knowledge about dementia care to be able to identify when a dementia patient is becoming unwell, to be able to signpost to relevant agencies, and to bring the risk back for MDT for discussion so that an MDT solution can be agreed.
Thanks, Adeniki. I just wanted to ask with the navigators, how well do they know all the sort of voluntary sector services, etc., that could be signposted to in the city? You know, we've got quite a lot now that are grant funded, and there's various things, you know, that go on in the city. And I'm just wondering how well those navigators know that to be able to signpost people to different things.
Okay, so the navigators were originally employed by the Alzheimer's Society, and so they were paid into the service over a year ago. So majority of them have quite a wealth of experience about all the services that are available to support patients with dementia and their carers. But obviously, even some people that joined also any services that we think will benefit the dementia service, we have a resource that, you know, inform all the staff about resources that are available. But sometimes if we come across a need, we bring it to the MDT and people give an idea of, oh, this is the services that we've worked it in the past and that they can signpost to. So we have a list of the resources that are available, which is we constantly update as we go along.
And obviously, we're very happy for you to inform us of other services or new services in the city or new things that are available for patients that we might not know about. So
it's probably worth saying as well that the navigators cover sort of patches so that they get very kind of used to their kind of area that they cover and the services within that. And yes, they share between each other, but they're also sort of based in an area. So, you know, their experience develops over time.
Thank you. I've got Liz and then Deborah.
Thank you, Chair. One thing back to the numbers of who goes to which practices. Surely a sense check on this is how many people have registered at the Neiman practice versus people who live in the city, just to get us somewhere, whether we're even in the right sort of ballpark. I have never met anyone who lives on the two big estates in the East who has gone to the Neiman practice. They all went to one on Brick Lane or the Crisp Street Market, or I don't know, Goodman Fields, maybe that's replaced one, it's a new one. I don't know, but there are ways of nailing this down. And obviously the socioeconomic demographics of those two estates versus where the Neiman practice is located is very different. Deborah might be able to help me on this one. We had a paper, I think it came from Port Health, that was brought to planning that showed that premature deaths from pollution were above the London average in the city, which is quite a shocking thing when you consider the lack of deprivation. And I would have thought this is something that could tie into potentially higher rates of dementia, I would have thought. And so I think there's actually a lot of questions. In the census paper, the numbers are just obviously not there. One thing about we've been talking about signposting and all of that. One statistic I have from ages ago from Age UK City of London is that the city has the highest proportion of single elderly households in the country. Now, when people are living alone, how are they finding a navigator when that can't be, it's got to be, the signposting has to be the reverse way of getting people who are in the community to recognize amongst their neighbors and then bring them forward. People won't, if you're living alone, you won't be able to, quite possibly able to present to say, I think I've got dementia. And I think that really needs to be looked at and it goes right back to the safeguarding when we have so many people who are elderly and living alone actually reaching the people who need these services. And I'm on that, other than you said the City Memory Clinic, I assume that's now the City Memory Group. I assume that's Mad's, whatever she calls it now, Forget Me Not Cafe. That's fine. But then everything else, I don't know how you would expect someone with dementia to get to Dalston or Homerton to actually access services. It feels incredibly unsatisfactory. Sorry.
Well, I mean, if patients can arrange, you know, there's hospital transport for patients to go to Homerton for scans, but that's, you know, that's where we have our providers. So and then the Dalston the Dalston singing for the brain, that it's it's in Dalston. But the cognitive stimulation therapy we provide transport for. So city patients who want to access that, we provide transport. We also, you know, if people can't get to our service, we can arrange transport for them as well for assessment. And we also do the navigators and nurses do only home visits unless people don't want to have a home visit. And we also, for people that can't get to our service for assessment, we also do home visits. So we try and be as, you know, accessible as we can.
Deborah?
Yes, a sort of a declaration of interest. I'm registered with the Imago Carers Network, and also the City of London Carers Informal Group. And it's just putting the focus on the carers element, because I think in this city, partly because of the socio-economic benefits, people do try to look after their family at home. And I think sometimes as situations with dementia escalate, the carers are just trying to sort of cope rather than look for help. So I think it's how perhaps the Neiman practice and others can let carers know that support is there, because I think carers do tend to just sort of soldier on until they fall over sometimes. And picking up from the point you were just making, I attended a session that Imago put on, yesterday, a sensory session for people with dementia. And the speaker operates out of St Joseph's Hospice, and they run kind of workshops and training at St Joseph's, but they don't offer workshops in the city. And again, I think the carers, there's just a few of us on the call, but the idea of having to organise ourselves to get to St Joseph's, to get training, to give our dementia people sensory sessions, it's just too much. Whereas if there was something, a workshop in the city, then we would sort of trot along quite happily. But it's just, although St Joseph's in Hackney or Dalston or Homerton might not sound far away, when you've got to organise for your person to be looked after so you can go out, it's very, very challenging. But I suppose because there's only a small number of us in the city, it can be quite awkward to organise sessions bespoke for us. So it's just a plea. I'm not quite sure how we would go about doing that, but I can say that the session was very helpful, and I would have loved to have been able to take part in a workshop, but I just can't make the time to go to St Joseph's. But it was a very helpful session.
Stephen, sorry.
Just one quick one on that. Not only can it be difficult to organise it, but it can be expensive if you have to get in a professional carer every time you want to go out.
But if there are no other comments, thank you to Emma and your team for presenting. It's been quite a robust session, but that's good. That's good. We're doing our job. So thank you very much, Nick and Robert for joining us, and Emma, and thank you.
Thank you. Thanks. That's well.
Are we ready to move to item 7?
Yeah.
Thanks.
My fear is that in 4 years' time, same discussion, or not, maybe not us, but someone will have the same discussion, and that 64% number will reappear.
So are we going to get hold of those slides? Will they be?
Yeah.
Yeah, we'll get the slides and we'll send them around. Apologies, they
Thank you very
were
much.
distributed in advance. Thank you.
Thank you.
So item 7, and I think Ian Tweed is going to talk to this, just noting that the appendices are in the non-public part of the agenda for a range of reasons.
Okay, thank you. Yeah, so this report outlines how direct payments are used across adult social care to try and enable more choice and control and power to the service user. For some, that's simply a choice of agency, moving from one agency to another rather than the commissioned agency. For others, it's more employing a directly employing a personal assistant that they have much more control over. But of course, with that, they become employers themselves. So there's more to that in terms of the paperwork. We do put services in to support people with that. We have a third party sort of bookkeeping service who can do all the kind of pay slips and pay runs and a lot of the admin from that. We also have a direct payment officer who is a Bengali speaker as well, can help engage with in the east of the city, and will go out with social workers to sort of explain direct payments and how they work. Apart from that, the audit just outlines that we've got an audit from internal audit, and it's given substantial assurance around compliance measures and controls. There was 4 areas where we had to make some minor adjustments which have been completed. And then just to add that we also have direct payments to carers, and these are slightly different. They're one-off payments for particular things. So they, there's a list in the sort of in the report about the kind of things that carers might spend that direct payment on. But happy to answer any questions.
Can I just ask, how does the 32%, how does that compare with national kind of take-ups?
It's slightly difficult because people have different calculations methods, but generally speaking, it measures quite well. I think it's important to note that that's a measure. It's not necessarily the higher the better. It's what it shows us is that we are giving the people the choice and control. We know it, for a lot of people it's not appropriate, so we're not expecting this to go to 60-70% or anything. This is just a measure of, till we can understand that we're definitely getting that measure out, that message out there and speaking to people.
Sorry, Deborah.
Can I ask, are the payments means tested at all? And if people take up the direct payments, does it affect any other benefits?
So for the carers, it's not means tested at all. But for the cared for, it is means tested. It's in line with the sort of national charging policy. So you may have to contribute towards it. Usually that will be what you would have is a pot, and you would have so much from the local authority, and you would make the rest up yourself in line with that. It shouldn't affect any benefits because it's going to the local authority. So it's not going to affect your benefit in terms of it's for your care and support needs. So it's not you can't spend that on your living expenses, etc.
Thank you, Chairman. Right, I'm a very strong proponent of direct payments where they are relevant, and I fully accept that they aren't relevant in all situations for reasons which are unfortunately all too obvious. It's been my experience looking around the country that there had been significant resistance by local authorities to making direct payments, partly because they lost control over what was happening. And that was highly regrettable. I thought the take-up and the offering of direct payments has been slower than I think it should have been and could have been nationally. I'm pleased to see our number of 32%, although I do accept this isn't a simple numbers game. What surprises me slightly is that over 90% of those who do take it up, and I know we're talking about small numbers here, so the percentages become a bit funny sometimes, but over 90% of those who have direct payments have those managed by the local authority or by the corporation. And it just surprises me that that so fewer than 10%, in fact 2 individuals, actually manage their own direct payments. Now, again, looking around the country, you wouldn't expect a very large number of people to manage their own direct payments, but I'd have expected more than 2 in the whole city. So are we steering people towards something which we think is good for them, or are we really managing to give the real options to individuals who are capable of and who want to manage their own money to allow them to do so?
I think, well, personally, I think often the managing the money is the barrier for somebody to taking up direct payments. So what we're doing is facilitating that for people who can't do it. It's not managed by us as a local authority. It's a third party that we commission to do that, so that we're trying to give as much distance as possible for that and to give as much control as possible to the adult. I think that's the ethos there, is more power to the adult and more control.
But only to have 2 individuals who actually manage their own money, that seems remarkably low.
It is. I must admit, I don't know what the comparators are to the rest of the country. I think the options are there, but people generally, that's what puts them off. That's what they don't want to do. That's what we find. A lot of people are not struggling up managing their own finances and don't want to start managing this. I think what we do find is the younger people tend to take that option, so rather than the older people.
And what does third-party management mean? It would actually happens.
So we commission an agency who will then take all the paperwork, so everything will go to them. So we will give them the money for the direct payment, and they will deal directly with all the sort of bills, expenses, etc. Make sure everything's paid. So we just deal with them in terms of the finances, and the finances don't have to be touched by the adult. If the adult wants it themselves, they have to set up their own bank account that's separate to their own bank account, and then they have to manage all the receipts coming in and make sure it goes back. So it's a lot more involved from that. And if you'll notice as well that the majority are personal assistants that are being employed. So if you're employing a personal assistant, you manage it yourself, then you have to do the tax, you have to do the pay slips, you have to do all these other things, which are going to put people off doing it because they don't want to be involved in that. So the third party can do that for them.
May I just suggest that it would be helpful, not in a big rush, but to look at the situation in other upper tier authorities, not merely in London, but around the country, to see what proportion of individuals actually do manage their own direct payments. Because the impression I have, and it's only an impression, I haven't got statistics to back it up, but the impression that I've got is that it is significantly more than the number that we've got who do that. And I do understand exactly why most people won't be in that position. That goes without saying. But for us only to have 2 individuals who are actually managing their own direct payment really does surprise me, especially given, going back to the last item, the socioeconomic lack of deprivation that we have in the city. And there should be more individuals who are capable of doing so in the city than in any other part of the country. And it still won't be a very large percentage, but I really would have thought it would be more than 2. So I just wonder if, as time goes on, you could try and get those statistics, comparative statistics, just to see what proportion of individuals actually manage their own direct payments in other parts of the country.
I think it's the point we can try and do that. The one thing I would say though is our numbers are so low. So if you had another person out of the 23, and suddenly the percentage shoots the other way. So the percentage is going to be a difficult comparator.
I've got Steve and then Liz. Okay, sorry.
When it's outsourced to the third party to do all the paperwork, and does that come out of the benefits, or is that an additional cost that the city pays? Because surely that doesn't come free. So where does that money to pay for that service come from?
That comes from the city. It comes from the adult social care budget.
Steve.
No, mine.
Is there any other questions or comments on the direct payments? In which case, I think we can thank you and move on to the next item.
Thank you. So the next item is any questions on matters relating to the work of the committee? And any other business?
Any other business? Can't see anything. No?
Thank you. Do we have members' agreement to exclude the public in line with the wording set out in item 10?
Is that agreed?
Yes.
Thank you.
Thank you. Just okay, so I can confirm that the live stream's